With over 200,000 people dead, COVID-19 is clearly a killer. But that is out of 7 billion people. So how deadly is COVID-19? Let's talk about that. It is very hard to answer the question, how deadly is COVID-19? We'll take a look at COVID-19 compared to the usual major causes of death, such as heart disease and cancer. We'll take a look at how deadly COVID-19 is on an average basis, the case fatality rate, and I'll try to give some insight into how you can answer the question, what is your risk of dying if you get COVID-19? At the time of this recording, there are well over 200,000 deaths worldwide. Where that will end up, nobody knows. It could be 500,000, it could be millions. It also depends on what you consider a death from COVID-19. According to the World Food Program, the interruptions in food supply may lead to a famine that could kill an additional 30 million people. We could look at body counts in the context of other worldwide epidemics and pandemics. COVID-19 kills almost as many people as the seasonal flu, and COVID-19 has only been around for 4 months. Another way we could put COVID-19 deaths in context is to look at the number of people who died in wars. In just 4 months, COVID-19 has killed more Americans than were killed in either Korea or the Vietnam War. We could compare COVID-19's death rate to the usual causes of mortality. In the United States, the most common causes of mortality are heart disease and cancer. But look at this week from April 6th to 12th. COVID-19 became a leading killer along with heart disease and cancer, and by the time you listen to this recording, it has probably surpassed heart disease and cancer as a leading cause of death. But wait, it turns out that depends on where you live. In that week, in New York State, COVID-19 was 4 times more deadly than heart disease or cancer combined, while in California, the effect was not so great. To answer the question of how deadly COVID-19 is to those who get it, we need to look at some rates. These are also called ratios. Rates have a numerator and a denominator. The numerator is how many people have the thing of interest. In this case, what we are interested in is death, specifically death from COVID-19. The denominator is how many people could have the thing of interest. These are cases of COVID-19. So if we have 50 cases of COVID-19 and 10 die, we have a case fatality rate of 20%. Often our numbers aren't accurate. Often we are missing data. Sometimes we have the data and we over or undercount the data. As a result, either our numerator or our denominator, or both, might be off. We can divide the number of deaths by the number of total cases. Hold on, first I need to explain what a case is. A case is an infected person who is tested positive for SARS-CoV-2, the coronavirus that causes COVID-19. Worldwide, the case fatality rate appears to be about 7%. Worldwide case fatality over time has increased, but appears to be leveling off roughly around 7%. But there's a problem. We measure deaths at the same time that we measure cases. Many of the cases are new and have not had a chance to either resolve or become deaths. It takes about 2 weeks for a typical death to occur. Perhaps it would be better to compare today's deaths with the number of cases that existed 2 weeks ago. We might call that the offset case fatality rate. So we take the current deaths, divide it by 2 weeks earlier's case count, and we come up with an offset case fatality rate of 11%. Another way to look at this is by resolution outcomes. If there are this many recovered and there are this many dead, we see that 20% of people are dead, 80% recover. So how deadly is COVID-19? The CDC estimates a little over 5%. The measured worldwide case fatality rate is 7%. A 2-week offset case fatality rate puts the number at 11%. And if we look at outcomes, 20% resolve to death. But wait, it turns out the case fatality rate varies widely by country. These numbers bounce around. These numbers will not be accurate by the time you look at this, but the principle applies. Case fatality depends largely on where you live. In the United States, case fatality varies widely across states. Now, it may be worthwhile to compare COVID-19's case fatality rate to other viruses. Rabies is 100% fatal if it isn't treated. Ebola is almost always fatal. The strain of influenza called avian flu, H5N1, has a very high mortality rate. Now let's look at the cousins of COVID-19, MERS and SARS. MERS and SARS had a fairly high mortality rate. The reason they were not pandemics is largely because they were not particularly contagious. COVID-19, on the other hand, is extremely contagious. Seasonal flu over here has a case fatality rate of only about 0.1%. Even the more serious swine flu, H1N1, has a mortality of only 0.2%. Where will COVID-19 end up? We don't know. It might be as low as 1%. It might be as high as 7%. We really do not know. But here's what we do know. Even if COVID-19's case fatality rate ends up being only 1%, that's still 10 times higher than seasonal flu. There are many pitfalls to trying to estimate the case fatality rate. Case fatality rates are deaths over cases, but there are many ways a case fatality rate can be higher or lower. Factors that might make the case fatality rate look higher than it is include counting deaths as COVID-19 deaths when they're not. That raises the numerator, or artificially lowering the denominator, either because of false negatives, which I'll get to in a minute, or because we are missing infected people who were never tested and therefore we don't know that they have COVID-19. Case fatality rates can also look lower than they really are. If we fail to count people who died of COVID-19, that will lower the numerator, but we could also artificially increase the denominator if we count suspected but unproven cases, or because of a number of reporting errors that can happen on various reports, such as death certificates. Here's another problem. Body counts aren't necessarily body counts. Let me explain. This graph happens to be about England and Wales, but the principle applies anywhere. The blue dots are the historical average of the number of deaths per week from any cause. We call that all-cause mortality. And of course, in March and April, all-cause mortality skyrocketed. However, this number represents the number that were reported as COVID-19 deaths. What about these people? These are people that died, and we do not know why they died. But there is really very little plausible explanation other than COVID-19. It is very likely we are undercounting COVID-19 deaths. The denominator can have problems too. There are really two major ones. The first one is false negatives. To understand false negatives, we have to understand test sensitivity. Test sensitivity asks the question, if a person has SARS-CoV-2 in the nasopharynx, how often do we accurately detect it using a PCR swab test? Wait, I need to explain what the nasopharynx is. This is a cross-section of a person looking to your left. This is the nasal cavity. This is the nasopharynx. We take a number of people that we know are infected, then we see how many of those had positive tests. In an ideal world, 100% would have positive tests. We are finding it's about 70%. The inverse of that number is the false negative. Imagine you test 10,000 people. 9,000 of them test negative, they do not have COVID-19. 1,000 of them have COVID-19. However, only 700 of them will have a positive PCR test. 300 of them will test negative even though they have COVID-19. What does that mean? This group thinks they are negative and they may go on to infect others. They also affect the denominator. We will calculate the case fatality rate as 200, the number of deaths we counted, over the number of positive tests. That gives us 5.7% in this hypothetical example. But remember, the true denominator includes people that have COVID-19 but tested negative. If we could count them, the case fatality rate would be 4%. False negatives lead to overestimates of the true case fatality rate. There are many reasons for there being false negatives. One important one is the incorrect collection of the swab. This is a nasal swab. This is not how we do the test. This is a nasopharyngeal swab. This is how we need to do the test. It's somewhat uncomfortable, and people may not agree to have it done. The second denominator problem we alluded to earlier, which is that we count cases and not infected. Let's look at 5 hypothetical groups. This group is infected but has never been tested. They either don't have symptoms or they haven't had symptoms yet. This group has very mild disease. They either didn't think they had COVID-19 or they didn't worry about it, and they also never got tested. Or perhaps they were afraid to get tested for any number of reasons. Then we have those who were tested and shown to have the disease, and we can divide them into mild disease, severe disease, and the most severe disease. Now let's put some numbers to these boxes. Remember, these are the cases because they've been tested, but these are the total number of infected people. Let's measure how many people in each group died. We come up with 68 dead. Now we will simplify these groups into those who are cases and those who are not cases, but remember, they are all infected. The counted number of dead was 68. What is our case fatality rate? It's 68 over 1,000. Is that really telling the story? To get a better story, we need the infection fatality ratio. That's the proportion of people who are infected who go on to die. If we counted total infected people, the infection fatality ratio cuts the case fatality ratio in half. A much better estimate. The problem is we do not know the infection fatality ratio because we do not know the number of infected people. And we cannot know the number of infected people until there is more widespread community testing and more accurate death reporting. Does the case fatality rate tell you very much about what your risk is? Not really. Imagine 750 low-risk people get COVID-19, 8 of them die, a case fatality rate for low-risk people of about 1%. 250 high-risk people get COVID-19, 60 of them die. Their case fatality rate is 24%. But what will be reported? You'll hear the overall case fatality rate, 68 over 1,000, 6.8%. If, however, you are in this group, your risk is probably more like 1%. If you are in this group, it is more like 24%. So the overall case fatality rate doesn't tell you much. A reminder, these are made-up numbers. Your risk of dying, if you are infected, depends on many things. There are virus-specific factors, many of which we do not know yet. As we saw, there is substantial geographic variation. At least a couple of weeks ago, the fatality rate in New York appeared much higher than in California. There are many social and economic factors. Access to health care, if you can't get to a hospital and you need a hospital, your risk is much higher. The capacity of the healthcare system is an important factor we've been focusing on for several weeks. If the healthcare system cannot provide you with the ventilators or critical care or medicines that you need if you get sick, then your risk of dying solely because of healthcare system inadequacy goes up. If you become critically ill with any illness, not just COVID-19, there are medical risk factors that increase your risk of dying. Medical risk factors that seem particularly important in COVID-19, however, include age over 70, obesity, diabetes, and high blood pressure. There's really only one thing we know for certain. If you don't get infected, you can't die of COVID-19. So let us recap. COVID-19 produces a high number of deaths in comparison to war deaths and other viral illnesses. The rate at which deaths are rising has slowed, but deaths are still rising with more than 2,000 per day. Case fatality rates are difficult to estimate due to potential problems with the numerator and denominator. We think that case fatality rates will land somewhere in the 1 to 7% range. We could be way off in that guess. Case fatality rates vary widely across countries. In the United States, case fatality rates vary widely across states. This is probably due to human behavior and testing differences. We simply cannot know how deadly COVID-19 is until we can calculate infection fatality rates rather than case fatality rates. Finally, reported case fatality rates are overall measures. They really do not tell you much about your individual risk of dying if you yourself were to get COVID-19. Thanks for watching. See you next time.